Hello, everybody, and welcome to our Rare Disease Day webinar on living with homozygous FH, homozygous familial hypercholesterolemia. Today, my name is Kat Davis Ahmed. I'm the Vice President for Policy and Outreach at the FH Foundation, and we're thrilled to have you all here, and especially honored to have Alison Jameson as our moderator for this webinar, and Dr. Barton Duell and Dr. Lisa Hudgins as our HoFH experts here on the webinar. We're so glad that you've all joined. So I want to make sure everybody knows this webinar is meant for information, but certainly not for medical advice. Please be sure to consult your own physician or find a specialist with our help if you have specific questions. Please introduce yourself in the chat. It's really important you choose panelists and attendees so that everybody can see your message. Otherwise, just a few people can see your message, and we want everybody to introduce themselves and get to know who's here. And thank you for joining. So please introduce yourself, choose panelists and attendees in the chat. And we really want you to have time to ask your questions and get your questions answered by our experts. And so please submit your questions throughout in the Q&A. And then Alison will take the questions at the end of towards the end of the program. So please enter your questions in the Q&A part instead of in the chat. We really want to thank and acknowledge our supporters for this program for the Rare Disease Day campaign, Regeneron for their generous support, and also to thank the family partners, families who really step up and help and support the FH Foundation's efforts and make events like this possible. Thank you. And we're just thrilled to have you all here at the homozygous FH community, and particularly to have Alison here to moderate today. Alison is just an incredible advocate for awareness and a board member at the FH Foundation. And I'm excited, and thank you very much, Alison, for moderating this evening.
Thank you, Kat. Yeah, thank you. I am so excited to be here. I know I've met several of you. I see some names I recognize, but my name is Alison Jameson. Like Kat said, I am a board member of the FH Foundation, and I am also a person living with HoFH. So probably like a lot of you here, this is something that has impacted me, and it's impacted my entire family. So just really excited to be able to be here and to be part of this great community. Tonight is your chance to hear from the experts. So I would like to introduce our panelists for tonight. We're thrilled to have with us. So we do have Dr. Barton Duell. He did a fellowship training in metabolism, endocrinology, and clinical nutrition at the University of Washington with a primary focus on lipid metabolism. He's a professor of medicine at the Oregon Health and Science University Center for Preventive Cardiology and the Knight Cardiovascular Institute and the Division of Endocrinology, Diabetes, and Clinical Nutrition. He's also director of the Lipid-Atherosclerosis Lab and the Sterols Analysis Lab, an Ldl Aphorisis unit, and he has a clinical practice that includes treatments of both children and adults with disorders of lipid metabolism, including FH. There's obviously a lot I could say about both of our panelists, but we'll do the brief version. We're also excited to welcome Dr. Lisa Hudgins. She is an associate professor of pediatrics in medicine at the Weill Cornell Medical College. And for 25 years, she has been the pediatric director of the Rogosin Institute Comprehensive Lipid Control Center at New York Presbyterian Hospital, Cornell. She has perhaps the largest practice of pediatric HoFH patients in the country and many years of experience with Ldl Aphorisis and clinical trials for new medications. And she's also on the Scientific Advisory Board of the FH Foundation and a principal investigator in the FH Cascade Registry. So I'd like to thank you both for joining us tonight and invite you to go ahead and turn on your cameras and turn on your microphones, and we'll get started tonight. So welcome to you both, and thanks for joining.
Welcome, everyone, and thank you, Alison, for having us be part of the program.
Absolutely. Well, why don't we get started with a little bit of background for everybody here. And let's just start, Dr. Duell, if you can kind of give an overview to everybody of what do we mean by HoFH? What are the differences between HoFH and HeFH?
Yes, thank you. So this is an area of confusion even among some physicians and other healthcare providers. And we generally classify FH into heterozygous FH, shown on the top, and homozygous FH, shown on the bottom. And technically, this means that the heterozygous FH patient has one mutant allele in the LDL receptor or genes related to the LDL receptor. And someone who's homozygous has mutant alleles, or both are mutant in either the LDL receptor or related genes. Now, it turns out there's a lot of overlap between the two. There are patients with homozygous FH who have LDL levels similar to those with heterozygous FH and the other way around, but it's a useful classification. Now, the most important distinction is in this third column here, and I'm not sure if you can see my pointer or not, but patients with heterozygous FH are considered possible if the LDL cholesterol level is greater than 190 milligrams per deciliter. Typically, levels are much higher than that. Mean levels in some studies are around 240 milligrams per deciliter. With homozygous FH, the levels can really range from 500 to over 1,000 milligrams per deciliter, but it's recommended to consider the possibility of homozygous FH if the LDL cholesterol level is greater than 400 milligrams per deciliter. Now, the speed of buildup of plaque is proportional to the LDL cholesterol level. So among patients with heterozygous FH, they may develop heart disease in the range of 30 to 60 years, but in patients with homozygous FH, it can occur even in early childhood. There are cases of children younger than 6 years with acute heart attack and other complications. So most people with heterozygous FH respond well to the medications. The response is less well in those with homozygous FH, and some of the most severely affected have minimal response to many of the drugs, although as you'll hear in a bit, some of the newer medications work regardless of how much LDL receptor activity is present. And then the frequency of the two is vastly different. So an estimate of the prevalence of heterozygous FH is around 1 in 250. In some populations more common than that, or a little less common. And then homozygous FH is thought to be present in about 3 or 4 per million. And so in the United States, with more than 300 million in the population, that means well over 1,000 individuals with homozygous FH, unfortunately, many of whom don't know they have it.
So understanding then the differences, can you also share with the audience how does this happen? Why does the LDL-C get high? What is sort of the biology or the chemistry behind that?
Yeah, it's an excellent question. And it turns out that the liver is critical for regulating cholesterol levels in the blood. And as shown on the left-hand side, this triangular organ, the reddish-brown organ is the liver. And normally the liver is very adept at pulling LDL particles, which are the main carrier of cholesterol in the blood, pulling them out of the blood and then either disposing of it in the bile or out into the toilet, or using it for other things. In familial hypercholesterolemia, patients who are heterozygous have roughly half normal levels, and so of the LDL receptor. So that allows maybe a doubling or tripling in the LDL cholesterol level in the blood. If somebody's homozygous, however, and especially with the worst form where they have no LDL receptors, then the LDL cholesterol level can be, as I said, as high as 1,000 or even 1,100 milligrams per deciliter. And as shown with the little figure of the artery here, that very high level of LDL in the blood then ends up being deposited in the artery at an accelerated rate.
So let's go into the artery a little bit more as well. So what is then the problem that this LDL is causing?
Yes, so the normal artery is shown in the left of these 3 slices through an artery. And during the initial stages of deposition of cholesterol and other lipids in the artery wall, plaque starts to accumulate, as indicated in the middle here. And at this point, it's not too much of a problem because the artery is still wide open and the plaque is in the early stages. As it progresses, though, two things happen. One is more severe narrowing of the artery occurs, but more importantly, this plaque that's developing is unstable and can form tears in it, for example, or have a rupture that then can cause an acute clotting of the artery. And that is what will precipitate either a heart attack or unstable angina. So the key to preventing this process or from trying to stop the progression once it's there is to eliminate the fuel for this, which is the very high levels of LDL cholesterol and related lipoproteins.
Right. And so as you shared at the beginning, this process in patients with HoFH can start very early in life. And Dr. Hudgins, you have a large pediatric practice in HoFH. So can you share with us, how you sort of approach the care of a pediatric patient, of children who are dealing with HoFH?
Sure. Well, let's take the scenario of a child who has been referred to me with an LDL cholesterol of 500. 400 we use in children as well as adults as the cut point for considering homozygous FH. And so the first thing I do is take a careful medical history. And so what that will involve is general health and listening for any other medical causes besides genetics for an LDL cholesterol this high. And that would include unusual problems such as liver disease, kidney disease, thyroid disease, diabetes, autoimmune disease. I also go through the medicines looking for cholesterol raising medicines. And sometimes cholesterol levels can be that high because of a combination of secondary medical causes. So that's an important step. Generally, however, I'm looking at a perfectly healthy child of normal, typically normal weight, not even overweight, normal blood pressure. So then I pretty quickly can move to family history. And the family history will tell me a lot about the origins of this very high LDL. And so here we're showing family trees. And even at 500, we need to consider the two forms that are defined really by the number of mutations, whether there's a mutation coming from both parents or a mutation coming from only one parent. And so on the left, we have heterozygous FH, and that just stands for one of the two pairs of, they're called alleles that we inherit from each parent is affected. And so these are the circles are females and the squares are males. And so when one of the two is affected, as shown here in the grandmother, that leads to the LDL levels in the 200 to 400 range. And here you have a normal grandfather, grandmother, and right away you see this mutation is being passed generation to generation, and that's a real tip-off for familial hypercholesterolemia, such that the granddaughter has inherited it. So this is 4 generations. So that's the pattern you see there. When both parents have 1 out of the 2 alleles abnormal, then there's a 1 out of 4 chance for the individual to have a double dose and the very high LDL levels. And that fits into the classic definition for homozygous familial hypercholesterolemia. So 1 in 4 chance of having a normal child, and then 2 out of 4 of having the heterozygous milder form. And then the person with homozygous FH, if they're fortunate enough to have the cholesterol checked and find that their spouse or does not have a mutation, will have heterozygous children. So after going through the family history and getting this picture of both parents having a very high LDL in the heterozygous range, 200 to 400, and unfortunately, often one of the parents has even had a heart attack already, or certainly the grandparent. Many of the parents are too young; they're in their 20s, whereas the heart attacks really start to take off in the 30s in heterozygous FH. So if I'm seeing this picture, then the physical exam takes me to focus on, first of all, the heart, and listening in particular for heart murmur, because not only the coronary arteries can get affected from the very high LDL cholesterol, but the aortic valve. So I listen to that. I listen for carotid bruits, and really there's not too much else except the skin findings. And so the skin findings are actually cholesterol that accumulates in foam cells in a very similar fashion to what's happening in the coronary wall and in the aortic valve. And they're called xanthomas. And they come in many different varieties, as shown here. They're more darkly pigmented in the darkly pigmented individuals. They can actually get into the tendons, typically on the backs of the hands, the knees, the elbows, and the backs of the ankles, and they can actually become painful and are confused, not recognized for the pain being caused from excess cholesterol deposited in the tissues. And so often, in fact, the kids are referred to me after this diagnosis has been missed, not only by the pediatrician, who can sometimes pass smaller ones off as molluscum, for instance, but also by the dermatologist. And it can even, and it's only until their skin biopsy that's formed, because that's performed, that the realization is that this is due to excess cholesterol backing up into the tissues. And it is in my experience, we have a registry, and 75% of the individuals in the registry were picked up by these xanthomas that typically appear at age 1 or 2.
And are there other manifestations as well?
Yeah. So then it's, when you see both of those, family history, high LDL plus physical. Oh, I'm sorry. Here's another physical sign. Now, these aren't as specific for familial hypercholesterolemia, but they certainly will coexist with the skin xanthomas, which are more diagnostic, the peripheral findings. And on the left, you see the xanthelasmas, tiny cholesterol deposits around the eyes. And then corneal arcus, which is a ring around the edge of the cornea, outlining the iris.
So after a family has been screened and has a diagnosis of HoFH for a child in the family, what are the sort of baseline studies or the tests that they should consider talking about with their physician to sort of get next steps for evaluation of a child with HoFH?
Yeah, well, actually, before these the evaluation of the heart, we want to, of course, do some laboratory screening for other medical causes to look for kidney disease, diabetes, thyroid disease. And we also would want to do DNA testing. And that can now be done as a saliva test. And it's being covered much more by insurance companies. The price has gone down, but that's still a limitation is the price and availability of this test. The FH Foundation, which you'll hear at the end, is offering free genetic testing for suspected homozygous FH. And so if you haven't had it done, it's important. It's important to distinguish it from heterozygous from homozygous FH because they carry different risks and different treatment and evaluation regimens. And it's also important to identify partial LDL receptor activity from complete loss of LDL receptor function, because some of our medicines will not work in the complete, with what we call receptor null individuals. And so I don't really wait for the DNA confirmation. I do wait to be sure that there's no secondary cause, but that's another week or so. There is an urgency. The cardiac evaluation cannot wait. Perfectly normal looking children without any complaints can have severe disease. The earliest reported is 18 months of age for a heart attack. And second is that even if it's normal at baseline, it can progress very quickly in the younger patients where we don't have a history of a more gradual process. And what do we recommend? We, of course, since I'm not a cardiologist, I get a cardiologist involved. So we set up right away an appointment with the cardiologist, and the basic cardiology exam is performed, as well as an EKG and an echocardiogram, a sound test of the heart. The echocardiogram is often where the workup stops, but the echocardiogram can only tell you about the aortic valve and whether it's narrow or not closing properly. And it can tell you a little bit about the openings of the coronary arteries, but not enough to exclude major coronary disease. And so for that reason, we go to one of two techniques. And what we choose depends on the age of the child. And so the coronary CT angiogram is reserved for children somewhere between 3 and 5 years of age, depending on their size. And the reason for that is that we need to use beta blockers to slow the heart. And if the child is too young, they can't tolerate a slow heart rate. Their normal heart rate is much higher than in older kids. And that if you don't do that, you get a poor picture. And this tells us about not just blockages in the coronary arteries that are supplying blood into the heart muscle, but also the amount of buildup in the wall of the artery. So it's very helpful. Kids will not calcify, so we're not looking for calcification. Then for the younger kids who can't tolerate the CT, and that requires, by the way, until the child is able to cooperate with breath holding, general anesthesia. So it's something that we're doing because it really has to be done. It's not just to see. And we do these evaluations for baseline because it tells us as we follow it over time whether we're holding steady or whether we have to go to more aggressive therapy and making the decision. And we'll talk about some of those more aggressive specialized treatments, has risks and benefits associated with them. And so it's important to define the extent of baseline disease to make therapeutic decisions. And obviously, if there's any treatment required, which sometimes is required at that stage, to open up blockages, that's important too. Coronary cath is for the younger kids. Coronary cath is also for those who have positive CT angiograms to get a better look. It has higher resolution. And again, that requires special, an experienced center. And we have the pediatric interventionalists, and we also try to have the adult interventionalists there at the same time. And at Cornell, that's easy to do because the pediatric hospital is right there on site with the adult group. And then over time, and sometimes at the beginning, we'll do stress testing to better define the impact of any blockages on heart function.
Great. So, Dr. Duell, I want us also to get into to treatment options, but just before we go to that, are there any differences in these steps that Dr. Hudgins outlined for adults? And also, do you see adult patients who come in to you not knowing that they have HoFH that are diagnosed as adults?
Yes, and those are a couple of important points. So on the one hand, the kids whom you've been hearing described are basically an accelerated version of what happens in adults. So the basic process is the same, but there are people who find out that they have homozygous FH well into adulthood. And so those tend to be people who have a milder form of the disorder and maybe are more resistant to formation of plaque. We do know from historical data that with no treatment, the outcome is pretty terrible with homozygous FH. Average age of first heart attack as a teenager. And so, but one key point to make here is that with aggressive intervention, we can alter that course. And I think that for me is one of the most important points of this whole session, is that it's a very serious disorder, but if you intervene and monitor closely, then there's reason for great optimism and great hope. I'd also add that this checklist is not a checklist that we just do every one of these. Obviously, with each patient, the type of evaluation that is done is individualized based on the circumstances that are going on, what kind of symptoms they may have, and sometimes we do things that are not on the list as well. And I'll just add in relation to genetic testing that I have one homozygous FH patient who developed xanthomas at age 10 or 12 and had LDL cholesterol levels of 600, 650 milligrams per deciliter. And his genetic testing is normal, shows no mutations. So he nonetheless has homozygous FH. So we can't necessarily rule out the disease on that basis. And then there is a recommendation to at least consider having genetic counseling before doing the testing, because there are various implications that need to be thought of that I won't go into at this level.
Right. Well, and I think I love that you said there's opportunity for hope. And I know that in my lifetime, I've seen new treatments come about. So why don't we move to talking about the treatments that are available for FH and HoFH in particular? And maybe Dr. Duell, you can kind of talk through some of the treatments that are used today.
Sure. So yeah, going back in time, you can see on the left-hand side are bile acid sequestrants, and the Questran was FDA approved decades ago, and it was typically used in combination with niacin. And for patients who are older who experience this, they not so lovingly refer to these as the fire and sand. The old Questran was like putting sand in your drink and getting it stuck in your teeth and so on.
I remember that.
Yes. And the bile acid sequestrants at very high doses, if people could tolerate them, might drop the LDL 10 to 30% in somebody with heterozygous FH, but minimal effect in somebody with homozygous FH. And similarly, niacin, if you take enough of it, can have a good effect, but side effects are a limitation there. And patients with homozygous FH are less responsive. So a major breakthrough in treatment of heart disease just around the world was the approval of statins, initially lovastatin, which was Mevacor back in 1987. And that really revolutionized the prevention and treatment of cardiovascular disease for all patients, but especially for those with familial hypercholesterolemia as well. Even among homozygous FH patients, the appearance of statins was associated with a 50% increase in longevity, just with the addition of statins alone. And the most potent statin, rosuvastatin, at a dose of 40 milligrams a day can drop the LDL cholesterol level by 60%. In people with heterozygous FH, it may be in the range of 10 or 20% in people with homozygous FH. I'm going to come back to Ldl apheresis, but ezetimibe came on the market, drops the LDL by an average of 18 to 20%. In heterozygous FH, less than 10% in homozygous FH. Lamidipide was FDA approved about the same time as mipamersen, which is no longer available. And it, at higher doses, can drop the LDL 50% and is FDA approved only for homozygous FH. The drugs that block PCSK9, alirocumab and evolocumab, are monoclonal antibodies that bind PCSK9. PCSK9 naturally destroys the LDL receptor. So by blocking PCSK9 with these drugs, the average LDL drop is about 50 to 60% in heterozygous FH. In patients who have no LDL receptor activity, and those are typically the people with LDL levels of 800 to 1,000, these drugs don't work at all because there's no LDL receptor to upregulate. Bempedoic acid has been on the market now for a year and is a drug that inhibits cholesterol synthesis like statins upstream from where statins work, and is modestly effective in heterozygous FH, dropping the LDL by about 23%. The efficacy really is not known in homozygous FH, but it's likely to be less potent. And then the newest on the market, approved just this month, is evinacumab, which is another monoclonal antibody that binds a protein that many physicians aren't familiar with, but something called ANGPTL3 that has a number of functions related to both LDL cholesterol metabolism and triglyceride metabolism. But by blocking ANGPTL3 with evinacumab, it drops the LDL cholesterol concentration by roughly 50%, even in patients with homozygous FH who have no LDL receptor activity. And it's similarly potent in patients who have heterozygous FH. So this is a particularly exciting new development. And I want to emphasize again, this is a long time span. This is over 50 years, basically, going from drugs that were moderately effective to these spectacularly effective drugs like the lamidipide, alirocumab, evolocumab, and evinacumab. And then Ldl apheresis is a concept that started actually back in the 70s, specifically for management of homozygous FH initially, because patients had a poor prognosis in the setting where LDL and cholesterol levels stayed too high. So Ldl apheresis was FDA approved in 1997, and it can acutely drop the LDL cholesterol concentration by about 85% by basically cleaning the blood. The blood is taken out of the body and processed, as you'll see in a little bit, and LDL is extracted. Other ApoB containing lipoproteins are extracted, like lipoprotein Ldl. And even the acute reduction actually is associated with improvement in blood flow to the heart, alteration in inflammatory markers, and other things like that. So It is not required for everybody, but it's important to lay all of these treatment options out on the table, because the work of treating homozygous FH is not done until the LDL cholesterol concentration is well managed and under control.
Yeah, and you mentioned some of the reduction capabilities of some of these medications, and I think we have some more in-depth information on some of the two that are specifically for HoFH. So you want to kind of explain what we're looking at on these charts?
Yes, so these are some recent data published late last year in the New England Journal of Medicine by Dr. Rawl in South Africa and others. And what's shown on this slide is a time course over 24 weeks, so 6-month study. And the y-axis here shows the percent change in the LDL cholesterol concentration with treatment with evinacumab, shown in these, I guess they're green, probably on your screen, or placebo, which are the blue and lighter blue symbols here. And as you can see, patients are stratified based on whether they were so-called null, meaning no functional LDL receptor activity. And patients who are null tend to have minimal responsiveness to statins, ezetimibe, many of these other drugs, including PCSK9 inhibitors. But in that setting, you can see whether they were null or not, they had a roughly 50% reduction in the LDL cholesterol concentration that was apparent within the first 2 weeks. So extremely rapid response, and then a sustained effect over the 6 months. And the next slide shows similar data for lamidopide, which has been available for clinical use for more time, as you saw in the previous slide. And it shows similar data, in this case going out for 90 weeks, so longer duration. There's no placebo control here, so that makes it harder to discern the absolute LDL reduction compared to placebo. But you can see in this particular trial with a small number of patients, you can see there was a roughly 50% drop in LDL cholesterol. Now, some of you who are on the call may actually be taking lamidopide and might be thinking, well, I didn't get that kind of reduction. And I'd emphasize this is average, and it is dependent on how much of a dose you can tolerate and how well you respond to it. So everybody's a little different in how they respond. But these two drugs in particular show you that spectacular reductions in LDL cholesterol can be achieved in patients who have homozygous FH, dropping levels to results that were not previously achievable in past decades with some of the older medications.
And now we talked about as well LDL apheresis as an option that is one that has been around for a longer period of time than some of these new ones. And we have some of our HoFH friends and superheroes on this slide. But perhaps you can share with us kind of what the process is and what happens during an apheresis treatment.
Yes. So one thing I'll say up front is that for both Dr. Hudgins and myself, starting apheresis is not the first thing to discuss. We work with all the other medications, and not everybody with homozygous FH needs LDL apheresis. For those who do, then it's a valuable tool to have available. And the determinant of whether we may use this or not is how successful we've been in getting the LDL cholesterol concentration down. And also depending on how extensive the coronary artery disease may be. So if the LDL is still higher than we want it to be, then it's a valuable tool to have available. And you can see this is not just pretending. Here's Tom getting apheresis. He's smiling. It is not innately a terrible thing to undergo. And this is the device that processes the blood, takes blood out of one vein, runs it through a column, You can't see it very well, but these columns are switching back and forth to bind the LDL. And then the clean blood is run back in through another vein. And it's a procedure that takes 3 or 4 hours. Some people can do this every 2 weeks. Many need it every week. And that's also something that is individualized for patients. I'll let Dr. Hudgins comment on Aubrey getting her apheresis. Some people think that children can't possibly do this, but as you can see, Aubrey's looking happy, playing on her phone, doing games or something. But Dr. Hudgins, I'll let you make a comment about this too.
Yes, so again, it's the patients who have insufficient reduction in the LDL who you know, are eligible for LDL apheresis. You know, if statin, ezetimibe, PCSK9 inhibitors, and there's a decision that has to be made to use juxtapid and now evinacumab instead of LDL apheresis, since we have these other drugs that have about the same LDL lowering. But often within the receptor nulls, we need it all. And so the youngest is going to come about even age 2, a large 2-year-old, it's even possible. In terms of fluid balance and maintaining a normal blood pressure, the recommended minimum weight is 15 kilogram, or about 30 some pounds. And we have to, when they're that young, we have to boost with albumin and do a number of other techniques to be sure the blood pressure is maintained. We also have to make sure that iron does not become depleted. That's a complication of this procedure, but it can be readily, the anemia can be readily corrected with iron administration. But apart from that, it can be well tolerated. What's really essential is to have an excellent nurse who can place the lines. And we try, we've been successful in almost every case in doing this procedure through peripheral veins, even in the youngest kid. But that really requires a nurse who knows the patient, a minimal amount of switching off among nurses, which unfortunately right now we have. Our longstanding nurse retired recently, but we're doing okay, but that's a big loss. And a nurse who has a connection with the patient to keep the mood up, basically. And for the younger patients, we have to keep them occupied and entertained. Otherwise, they'll just rip the catheters out. We have to even put a board to hold the arm straight so that that catheter doesn't come out, because they really do get restless. The older kids, of course, especially the teenagers, I must say, can begin to have quite a bit of hostility and having to come in. And so that requires a lot of discussion and reassurance and education about why this is necessary. There is a real inconvenience in the quality in lifestyle, meaning that parents have to take off from work, kids miss school, parents have to pay for the transportation, which can sometimes be quite long distances, even plane rides. And then even parking fees is a lot for some patients. And so the decision to go forward with LDL apheresis requires a lot of judgment and taking into account the family's situation.
And there's been a question, Dr. Hudgins, in the Q&A sort of related to that. And I do want us to have time to get to the questions. So if I can, we have just a quick preview of some upcoming treatments. Then I'd like to go ahead and go to the Q&A so we can get to some of these questions when the audience has access to your expertise. So we do have some clinical trial information. We'll just share that quickly. Dr. Duell, if you can maybe just give a quick overview of that, and then we can go to some of these questions that we're getting at what you were talking about, Dr. Hudgins.
Yes, we'll hurry through this so we can get to the Q&A, which is the most important part. So I would just summarize this by saying new drugs are coming. Inclisiran's actually approved in Europe, works similarly to the alirocumab and evolocumab. There's another drug for blocking ANGPTL3. Gene therapy was going on for a while, and there's a new approach of using CRISPR to modify certain genes. So that is very far from being clinically used. So a couple of other drugs are in development as well. So there's reason for further optimism, I believe, for patients with homozygous FH.
Great. Thank you. And I want to share some resources for the HoFH community, but I might do that as a wrap up. Again, I think some of these questions are relevant to where we are in our conversation now. So there is a question in the Q&A about what are the targets for HoFH patients? What is the LDL target?
Yeah, so I'll answer first. You'll get a different answer from both of us. And there's kind of the wish list and then the reality. And so the one number I tell patients is that the average LDL cholesterol concentration at which plaque buildup stops is around 70 milligrams per deciliter. So if we know somebody has coronary artery disease, just in general, that's the goal, is to get the LDL at least less than that. If it's a young person, if we can do it, even getting it down to 50 milligrams per deciliter, maybe even better. So on the other hand, though, if the LDL starts out at 1,000 milligrams per deciliter, then we just keep pushing ahead until we get the LDL as low as we can get it within those constraints. I'll pass it off to you, Dr. Hudgins.
Yeah, well, first of all, it depends on the baseline coronary disease, extent of disease. And I say that because so then you've got to, then you're more willing to push lower, obviously. So in kids, the recommended goals are less than 100 if there is coronary disease, and then less than 130 if there's not. Now you might ask, well, what about aortic valve disease, which can occur in the absence of coronary disease? And it requires a discussion at a different time, but it looks like the aortic valve disease in the homozygote may not respond, may continue to progress despite significant LDL lowering. But we still just keep, if it's a child with just valvular disease, we still push to try to reach the goal. There's another component in the pediatric management is the age. So the age will tell us how exposed the arteries have been because it's present from birth. And if you catch a child very young, say 4 or 5, and you do a baseline coronary angiogram and echocardiogram for the valves, and you see nothing, I've been comfortable stopping in the heterozygous range. If the decision means Ldl apheresis, the drug that's very difficult to take with potential liver toxicity, Juxtapid, and even an evinacumab, that's new and it's not approved. All these drugs, those two drugs are not approved for kids. So, but that's what it would mean going off label for those latter two drugs in a young child. The evinacumab is 12 and older. So it's my thinking that if the arteries are clear, young and in life, and you lower it, and this usually just occurs, by the way, in receptor defective with statin ezetimibe alone. But if you lower it into 200 range, the LDL, then it might buy you several decades, 20, even 30 years, until we come up with something else or we have more experience with these better drugs.
Mhm.
And we don't have any evidence that that's the case, but a heterozygote at age 5 with an LDL of 200 has at least, you typically till age 30, if untreated, before getting into trouble. So that's my reasoning. And so we need more research to test that out. But otherwise, those nulls with the starting at 800, you just have to keep piling on the treatments.
Yeah, so we've used the term null a couple of times, and I think you guys did a great job of kind of explaining what that means. But there is a question about, how do you know if someone is a null homozygous? Is it strictly the levels? Is it response to medications? How do you make that determination?
Yeah, it's all of the above, really. And,
Yeah,
and the
yeah,
genetic
that's a very good
testing can give
question.
clues about that.
Yeah, what we need is an accurate functional test, really, because the definition of activity of the LDL receptor, there's often poor agreement among the various labs in defining what's actually pathogenic and what's not.
But in a
So,
way, it doesn't matter because you still will give the drugs anyway. And there are people who
well,
shouldn't
I
respond.
don't mean well,
Yeah.
I have not used PCSK9 inhibitors in the receptor nulls.
No, in the receptor nulls, they don't work. But the
Yes, I
people
mean,
with,
it does change management, and it,
yeah,
and the statins, and yes, the response to statin, the lack of response to statin and ezetimibe is a clue.
mhm.
And sometimes I'll use that over what the DNA testing is telling me about receptor function.
Mhm. So the next question is one that I know I personally had to face as well, and this may be a matter of opinion rather than fact. But if you are thinking of, if you know you have HoFH and you're thinking about starting a family of your own, you're thinking about pregnancy, what considerations should you take into account?
Yeah, I'll make a comment. And when I get asked this question of the patient with homozygous FH, one thing I ask them is the world better off because you're here? Would you prefer not to be here? And the usual answer is, of course, they are glad to be here. So it is a big deal, though, to have a child with homozygous FH. And so first thing is, we sometimes jokingly say, pick a spouse who doesn't have FH. And in that case, then the worst you can pass on is heterozygous FH, which is a usually pretty easily manageable disorder. If you have a spouse who has homozygous FH, then all of your kids will have homozygous FH, and you just have to, I guess, plan appropriately for that and make a decision that's not an easy one.
Yes, and I would just like to add that during pregnancy, cholesterol levels in a normal individual go up, and that's the same is true in a patient with homozygous FH. And so it's important to have a cardiology evaluation even before deciding to get pregnant, and then careful, supervision. And the only medicine that's approved during pregnancy or accepted, there's not a lot of data behind the approvals, are the bile acid sequestrants.
And then LDL apheresis,
And
certainly.
LDL apheresis.
Yeah. Yeah, and as the non-medical professional here, I can tell you, I did have a pregnancy and I did apheresis while I was pregnant. So that's my case study of one.
Right.
we have a couple other questions. Some I think are a couple of quick answers. We saw some pictures of the xanthomas and xanthelasmas. Are there any other places that you might see these, as someone's asking specifically about maybe in the balls of the feet, or are there other places on the body that you might see those physical manifestations?
Yes, there's one place that actually should be part of the physical exam in any child with familial hypercholesterolemia, and that's in the buttock crease. And to the point where in one of my patients, it became so irritated and inflamed because they were quite large. And she ended up, even with an LDL still running in the 400 range, having it excised, even knowing that there's the potential of it growing back, having not reduced the cholesterol that far. But the other is that rarely it's even been reported intracranially. And but it can really, be quite extensive and disfiguring. Lowering the LDL, however, almost universally leads to some degree of flattening, and often complete flattening if the levels can be lowered sufficiently.
Yeah, and they can be in areas of pressure, rubbing, irritation on the feet, sometimes even on the toes or elbows, knuckles, various places.
Okay. All right. And then Dr. Hudgins, you were sort of referencing this. We have a question from a parent of an HoFH teenager about the stress that LDL apheresis can present to children and teenagers. So do you think that the medical community should consider a psychological standard of care for HoFH kids to help them, especially during these times when it's difficult enough to be a teenager? Have there been talks around that sort of new standard of care psychologically?
Well, there's been attention drawn to the need for that, but definitely nothing standardized. And I think it's an interesting thought, whether there's something specific, and we could learn by talking to other units and all, how various units handle it, and come up with something like that. Yeah.
Yeah, we actually in our cardiology clinic have a clinical psychologist who focuses mostly on congenital heart disease, but with this whole issue that sometimes we as physicians, we focus on the numbers, the LDL and managing the heart disease, but living day-to-day life is a equally important factor. So I believe more is needed in that regard, and certainly each person may have special needs that need to be addressed as well. And sometimes just the pediatrician can help with some of that, but getting counseling or other kinds of support, both for the child and the parents, can be helpful in some cases.
And then it's sort of talking about how apheresis can impact quality of life and the way that you go about your life. Once you start apheresis, is it a rest of your life treatment, or are there opportunities to come off once you've started it?
Come on, after what we've just heard?
Yeah,
I stopped it. I can tell you that.
That's a big excitement. My patients are really having quite a celebration. It's clearly been shown that both of those drugs presented with 50% lowering in certain patients can lead either to less frequent, longer intervals between treatments, or completely stopping it, and that's even keeping the LDL less than 100. So it gives you an idea of how good these drugs can be.
Yes.
In terms of LDL lowering.
Now, I would second that for some, they need to be on it. One of my patients is getting evinacumab, has been on it for a year experimentally, is getting alirocumab or evolocumab, and still needs LDL apheresis. But despite the inconvenience and problems that you heard about, this patient loves being on LDL apheresis. When she first started, to walk from the parking lot to the apheresis unit, she had to rest 5 or 6 times. Now she walks all the way, doesn't have to rest. Her chest pain is improved, and so there are tremendous benefits that for many people outweigh the inconvenience.
And I'm glad you reminded me of my first patient who started, it was still experimental then, at Rockefeller at age 5, is now 41, and he has refused all medicines, including statins and ezetimibe, and just does Ldl apheresis. And he's, you know, heart disease free, and you know, still hanging in there.
Yeah.
Well, and I think as you have both said throughout the night, it is an individualized approach. Everyone is different in the treatments that they tolerate and in the levels and what they're trying to achieve. So I think that makes a lot of sense. I think we'll answer one more question, and then if I could wrap up with just reviewing some of the resources that are available to our HoFH community. We talked about valvular involvement. So if you have an HoFH patient with aortic valve stenosis, is that calcification due to the LDL, or is there another reason that the calcification of the stenosis is occurring?
Well, you want to answer that?
No, go ahead.
No,
Or if you want me to go ahead.
You're going to be better.
No, I wanted to hear from you. Yeah, so basically the aortic valve develops xanthomas. So the composition is similar to what occurs in the tendons as well. And that's driven in theory in large part by the very high LDL cholesterol level. But as you heard earlier, getting the LDL cholesterol level down doesn't necessarily stop the process. And part of that might be that once the horse is out of the barn, so to speak, it's harder to rein it in. But not everybody gets it either. So it suggests that maybe there are some other factors that influence genetic susceptibility to developing the xanthomas. And it's just something that needs to be monitored over time, and there's not anything specific to be done about the aortic stenosis itself other than standard therapies for that.
Great.
Well, until it causes heart failure, then it needs to be.
Well, then you might need a valve replacement if it gets severe, but there's not another drug that just stops the.
That's correct.
The aortic stenosis.
Yes, I had my aortic valve replaced, so familiar with that one too.
Yeah.
So thank you both for that. And I do want to just for our families and patients attending tonight, share a little bit of information from the FH Foundation, the resources that are available. So this map I think is really interesting. This is from the FH Foundation National Database, and you can see that the blue dots show individuals in our database who have total cholesterol above 550 and are not diagnosed with FH or HoFH. So it's likely that they have it or that they have a serious lipid disorder, but are not yet diagnosed. And then the red dots are the FH specialists who are in those areas. So it's part of the central core of the mission of the FH Foundation to not only identify these patients, but of course then to get them in touch with the specialists so that we can be treated and treated aggressively and appropriately. So that's one of the many things that the FH Foundation works on for our patients. And if you are looking to find an FH specialist for yourself, on the FH Foundation website, you can see the web address there. You can go and enter your information and find a specialist near you. You can find a recommendation for someone who is familiar with this condition, who are experts like Dr. Duell and Dr. Hudgins, so that you can make sure that you are getting the best possible care that is available for this condition. And then, I would encourage anyone to join the HoFH community. I know I have shared my story with a lot of people, and I was 35 years old before I met anyone else like me. And I met them through the HoFH Foundation. All the beautiful children and people you see in this picture, just also a piece of my heart. And it really is so incredible to meet others who are going through this, to compare stories, to offer support. So you can, again, go to the website. You see here, we're in the HoFH community. You can sign up so that you become a part, you are notified with our newsletters. We have a Facebook chat group where there's just tons of opportunities to find support and to hear from others. We also have on the website, if you're interested in clinical trials, I personally have participated in 2. I find it incredibly rewarding, and also it's been great for my LDL levels. But there is a listing on the FH Foundation website where you can see some of these trials that are open, that are enrolling, who they're for, where it is, and all that information. So we try to really distill it down for you so you can see the ones that are relevant to us. And then there are a ton of other materials. So if you haven't visited the website, there's educational tools. We have a newsletter, as I said, there's flyers you can print out and share in your community, take to your own doctor's office to share with family members. We have a newsletter where you can be notified. We sent out the notice of the evinacumab approval. So keeping everybody in the loop together. So just tremendous resources there. And I hope that you will all take advantage of those. It is a very high touch organization, so we encourage you also to reach out. And I would be happy to personally connect with you if you have questions. You can see here on this slide, you can reach the FH Foundation here. I've also put my personal email address. Yes, I still have AOL, so I'm dating myself there, but I am happy to answer from the patient perspective, from an FH board member. And we're just really, really excited that you were here today. Dr. Duell, Dr. Hudgins, I cannot thank you enough on behalf of the foundation, of the patients, and of myself for offering your expertise tonight. If you would like to make any closing remarks, I'd invite you to do that, but just want to sincerely express our appreciation for your time tonight.
Well, thank you, Alison, for having us. It's an honor to be part of the program, and so nice to share it with you. And I just want to emphasize what I said earlier about being optimistic about homozygous FH. You've heard that it's a very serious condition, but if it's treated aggressively, then there are people such as yourself who are here to tell us about it and doing well. And so the key is to, number one, diagnose it. And then once you know, you don't wait a few years to start treatment. You start treatment as soon as you know the diagnosis, and you keep adding on therapies until you get the LDL cholesterol level under control. And to the extent that you control the LDL, then you essentially normalize the disease state. And so I have a patient who's in her 80s now with homozygous FH. So this is not a dire thing unless you don't treat it, basically. So there's reason to be very optimistic about this.
And I also have the same optimism. When I first started, my patients had only the bile acid sequestrants and a surgery that's no longer used for this disorder called porticable shunt surgery. Mm-hmm. And before the FH Foundation, there was absolutely minimal knowledge of FH in this country. And thank you, FH Foundation, for playing such an important role in educating the public and encouraging progress. The challenge is to identify it early. But to do that, we need the resources to treat, because there's no point in identifying without being able to lower the LDL sufficiently. And that includes things like Ldl Aphorisis centers, lipid specialists, and of course, insurance coverage for all of these things. The financial aspect is very important. And then of course, more research is always essential for progress.
Wonderful.
Yes, and hooray for the FH Foundation.
Hooray, thank you. All right, well, thank you both, and thank you everyone for attending and for asking your questions and sharing your stories. I will look forward to hearing from you. Don't be afraid to reach out and stay in touch with the FH Foundation. Thanks so much.
Thank you, everybody.
Thank you. Bye,
Thank you.
everyone.